I think Dr. Shah was mentioning we got a good turnout. I'm glad, usually by the end of the classes, especially classes that don't have a project or final, you get this tapering off and about half of people show up. So I'm glad that we pretty much have everyone here, it looks like. So thanks for coming. I'll save my remarks. Normally, as you know, I make some remarks at the beginning before the talks, but because today's the last class, I'm going to save my remarks to the end, the last 5 minutes. So really pleased in welcoming Dr. Sumit Shah, one of our experts, oncologists, but he's going to talk about, so today's topic is the future of oncology care, cancer care, and he's going to talk about digital health in the context of cancer care. So join me in welcoming Dr. Shah.
Great. Thank you so much for having me. I think it's a great testament to what Brian, Longshaw, and Richard have all built that you all are here today. It's really inspiring as an oncologist to see the next generation of hopefully future oncologists who are budding here in the room, either oncology through clinical practice or through research or through digital health or whatever path you have. You can see that the impact that you can potentially make on individuals. So I'm really grateful to Brian for sharing his story and hopefully inspiring the next generation to go solve this problem that we're very eager to have a solution for. So today, I know Dr. Neal is going to come to talk to you guys about the future of lung cancer therapeutics. And I think that's a really interesting and fascinating topic. My topic today will be not so much on the therapeutic landscape, but what about healthcare delivery and how will cancer care look like in the next 10, 20 years, okay? And we're in this era of digital health, and there's probably been no more exciting era than ever in human history than the era that we are in now with everything going on in AI right now and LLMs and all that kind of good stuff. So I think we're on the brink of some really transformational technology that will help kind of push oncology care to the more modern era like it has in many other industries. Today we'll be talking about the future of oncology care and healthcare delivery in digital health. So first, just wanted to mention that, we talk about a lot of these new sexy kind of LLMs and AI models and whatnot, but a lot of what healthcare is pretty still rudimentary, unfortunately. And I think that you might be shocked that some of the things I'll be talking about today are not that technologically advanced, but if we can actually implement them into our current system, it would actually make vast improvements in where our current status quo is. So even for the first example here, the first application of like digital health that we often do, that we think about these days, is just the explosion of mobile health, right? And you guys have seen mobile health, and you guys probably use a lot of mobile health yourself in terms of these like direct-to-consumer kind of apps that we have now, where if you want anything from mental health to see like a behavioral therapist, to if you want Viagra now, you can actually see a physician on your phone at the click of a button. But now we have 2/3 of the world's population. While many may not even have access to running water, still people have access to a smartphone though. And now with 2/3 of the world's population having a smartphone in their hands, we can actually access patients in a way that we've never had before. One of the actual practical implications that we have, practical applications that we have of using mobile platforms in oncology is just using PROs, which are patient-reported outcomes. And some of you may have seen this before, but again, not too much of a novel concept. But to really appreciate this, you have to appreciate the current system that we have. So right now, I just got out of my clinic. I treat a lot of prostate cancer, kidney cancer, and other types of urologic cancers. And we just gave a man for prostate cancer his Lupron shot, right, to keep his testosterone low. Now, I'm not going to see that gentleman for the next 3 months. He's on some Lupron shots. He's also on a few other pills. And essentially, he kind of goes into a black box. And I don't really know what happens to him until my next 3-month appointment with him. And then he tells me, oh, doc, over the last 3 months, I was getting really bad fatigue. I had some bad night sweats. One day I got really dizzy. I had to go to the emergency room because I was really low on my blood pressure. And we sit there thinking, man, if only I had known that in advance, maybe we could have done something to prevent that, right? So again, not a really novel concept here. But what we're doing now is that we have a web-based portal that is offered to that patient so they can actually fill out surveys about how their symptoms are doing over time. So now when I see Mr. Jones in my clinic, I can say, hey, we see that, or not even in my clinic, but we see on my computer dashboard is that I see that Mr. Jones, you've been having escalating levels of pain in the last 3 weeks. Before you actually call us, or before you end up in a local emergency room, maybe we can reach out prophylactically, right, and preventively to avoid that ED admission, right? So this is like this introduction of what we call electronic patient-reported outcomes. Again, not super tech fancy, but if you actually implemented this in a clinical trial, we had 800 patients with stage 4 cancer, all various types. They were all treated the exact same way in terms of their usual standard of care. However, half the patients had usual standard of care versus the other half of the patients had access to this web-based portal. And this is 6 or 7 years ago, so they actually had to log on to a laptop and actually report their symptoms. These days, it's a lot more sophisticated than that. But just that one intervention, just being able to report your symptoms to your doctors on a more regular basis, actually led to an overall survival benefit for those patients. So we already saw that there was improved quality of life, which makes sense because you're able to get to symptoms sooner. We also saw that there's decreased healthcare utilization because you can maybe intervene before that patient goes to the emergency room. But we were pretty shocked to see that you can actually lead to improvements in survival just because you're able to get to symptoms faster, right? So I think for one, these patients are getting less complications from their treatments, and two, is that they're actually on their treatments longer because they're able to tolerate it better, right? So things like this can actually be very beneficial. We've been working with a company called Memora in the last several months, using them almost as a digital companion, right? You probably get this like when you're going to United Airlines and you're at SFO for winter break, you'll get a text message that says, oh, by the way, John, your gate has changed to D34, right? In theory, it'd be really nice to receive that from your healthcare provider. You know, Mrs. Smith, today is your day 5 of chemotherapy. Don't forget to take your dexamethasone steroid pills as well, right? So those electronic reminders and ability to kind of interface with a chatbot, I think will be very helpful. Here you can see that this patient is saying that, hey, I'm really nauseous today. Is this normal? And then the chatbot will kind of help reassure them, potentially even offer medication advice, and try to help them navigate through that journey. Because doing this manually is very difficult, and patients are often very complex and need a lot of care. So these types of interventions can actually be very meaningful to our patients. The next intervention is actually...
For the previous study, can you give us a sense for the magnitude of survival benefit relative to, say, a new chemotherapeutic agent?
Great point, Brian. Yeah, so it's fascinating. There was a 4-month overall survival benefit. Okay, and some people would say, well, 4 months doesn't sound like a lot of time, but I can assure you that, you know, if you have stage 4 disease, that 4 months might be meaningful, right? Especially if you think about this time around the holidays. If that means one more, you know, Christmas with your family, so much the better. But two is that most of the drugs that we actually come to fruition that are even FDA approved may only have a benefit of 2, 3, 4, 5 weeks even, and they get FDA approved, and those become blockbuster drugs, right? So if you had that intervention bottled up as a pill, that would be a blockbuster billion-dollar drug that Pfizer or whoever can actually produce. But because it's like more of like a healthcare kind of distribution kind of effect, you know, it's not something that we can kind of bottle up and just like sell to people per se. But you know, it is it's a great question, and it also underscores that just by small interventions in the way that we deliver care, we can take you know a huge benefit for our patients. Though. Yeah.
And how fast did this reflect in the guidelines? That was something that impressed me from what I remember.
Correct, yeah.
Was how fast the evidence turned into practice.
Yeah, exactly. It's a great point. So the issue that it's all about, the secret sauce here is all about implementation. I would say almost no large major academic medical centers have actually successfully implemented this because, again, it's not the technology. It's really about implementing the technology into our workflows. Is this program, for instance, this one happens to be integrated into Epic, our EHR, but many of them are not. You have to get your nurse. It's not really the physicians who are doing most of the work. It's the nurse coordinators. So do they want this or not? You know, does this actually decrease, you know, my health messages, especially in the maybe you have to think about our patient population in the Bay Area, who's already relatively pretty tech savvy. This might work out really well in rural Idaho, where patients may not be as sophisticated to reach out to the providers as often as your Bay Area patients and whatnot, and you know, as adept with technology. But so there's a lot of caveats around this as well. But I will say that it's not implemented in the guidelines, largely because it hasn't been shown outside of a clinical trial to actually be worthwhile. But we're working on that here at Stanford, though. So the next intervention, I'd say, again, is nothing too rocket science, is this telemedicine. And this has really exploded in the last decade, largely due to 2 reasons. So as one of the champions of virtual health here at Stanford, I was trying to wave the flag. Dr. Neal and I both were trying to wave the banner for virtual health back in 2018, 2019, and we got about 2% utilization of virtual visits in 2020. And then obviously, the pandemic was a force function and really forced us to do overnight video visits overnight, right? And so this is actually for the whole enterprise. But I can say that for oncology, we went from 2% utilization to 80% utilization of video visits overnight on March 17th, 2020. And I will say that in oncology, this has continued the trend. So we're down to maybe about 60%, but we're still above most other subspecialties, though. And that's largely because in oncology, it's kind of depending on which field of oncology that you're in, most of the information that you need is actually objective data that you get by looking at a CT scan. For me, looking at a PSA for prostate cancer, asking the patient how they feel, right? And that actually tells me the 99% of the data that I need to understand if I should give treatment or not. So it allows patients to be seen outside our typical geographic barriers and allowed us to reach patients in a very different way. I think what this sets the stage for then is, can we actually change the care model completely and think about more home-based care, right? So you can actually imagine a scenario where we have a patient who is seeing their doctor now virtually, as opposed to what we did 5 years ago where you had to see them in person. So you have a virtual care visit with your physician. Now I'm reviewing all that remote patient monitoring data, or that EPROs, those patient-reported outcomes. I'm able to see your symptoms, your vital signs. And then I'm able to give you a thumbs up or thumbs down based on whether you should get treatment or not. I can then click a little button that enables your self-injector injection pen to unlock, and then you can actually administer yourself potentially immunotherapy or take a pill for a oral chemotherapeutic. And then we can use, again, those EPROs and remote patient monitoring to monitor how you're feeling, and then we can do a video visit again. So we're thinking about like more decentralized models, kind of like what we've seen in other avenues, right? In other markets. So we've seen markets like in entertainment, for instance. Back in the 70s and 80s, when you wanted to go watch a movie, you go to the theater, right? And then in the 90s, Blockbuster came along, and you guys probably don't even remember Blockbuster, but Ryan does, and you go rent a VHS, right? But nowadays, you guys are just at home now. On Netflix, essentially, right? So it's a distributed model, and we're learning to get there in healthcare as well. So I think that we're on the path towards probably decentralized models and distributed models within the next decade or so. There's a lot of regulatory issues around this, and obviously I think patient safety is paramount. But we're starting to see a lot more, many of our drugs that were used to be IV are now going to subcutaneous. A lot of the drugs that were IV are also going to PO, oral drugs as well. So I think we're getting to the point where we can start to think about how do we transition care from a centralized hospital setting to a more decentralized home-based setting. And I'm hoping that we see this in the next decade. Things like wearable devices will also be very helpful as well. There was a recent study done out of Stanford as well, using a mobile device to actually sense dehydration amongst patients with head and neck cancer. And they showed that just by having a mobile device that can actually sense your heart rate and your kind of internal blood pressures, that they're actually able to prevent admissions for patients with head and neck cancer compared to those who do not have the sensor, though. So we're getting to a point now where we can start to really think about how do we actually place these kinds of wearable devices and sensors in high-risk patients to keep them out of the hospital and hopefully maintain them on their therapy. The next big application is something that's been a big buzzword, is this big data in informatics space. But again, to really appreciate this, you really have to understand the mess that we're in right now in healthcare and how fragmented all our data silos are. So right now, when we see a patient in clinic, their scans are sitting in a different data center than their pathology, and that sits differently from their clinical notes, and that sits differently from their laboratory values as well. So we have all these discrete data silos that are not interconnected, unfortunately. And you can imagine, as you guys, many of you engineers out there, this is just something that low-hanging fruit to be able to integrate all that data so we can start to make inferences about novel pathways for patients going forward. But to this day, which is kind of alarming, even at Stanford, as a physician at Stanford in 2024, I can't answer basic questions that my patients ask me in clinic. They may ask me, how many patients do you see last year who were similar to me? I can't answer that question. I don't know exactly. I can probably find out, but it's not something that, in theory, you should be able to push a button and find out the answer really easily. I don't have a great way of doing that. How do your cancer patients do? How do your patients with cancer do? If you have a patient like me, what is my expected survival under your care? I don't know. I don't know what that is, right? So this is all data that's still kind of blind to me. Again, we can probably figure it out, but it's not easy, and it's not really like a dashboard that we have right in front of us. So there's a lot of people tackling this problem. One of the companies is called Tempest, for instance, and Dr. Neil and I have both used them before. And essentially, they're trying to connect all the different data silos that we have. So we have, genomic information, right? Are you EGFR mutant? And then can we actually connect that to your clinical care notes that you have in the clinic that tell us like when you're actually progressing or if you have certain symptoms? Can we then actually use that information to give you insights about other patients who are like you? So can I say, hey, I have all this information about Mr. Mrs. Smith, and now I have to see that I have 1,200 other patients around the country that are like Mrs. Smith based on her genomic profile, her clinical care, and her prior medications. Based on those 1,200 people, this is the best treatment for you, right? So that's kind of where we want to go in oncology. Not quite there yet. And then take it one step further. Based on all the information, Mrs. Jones, I actually have 2 trials for you that would fit your case exactly. One of them is in San Francisco, but are you also willing to go down to Los Angeles to consider another clinical trial that we think would be a good fit for you, right? So clinical trial matching is going to be really important here too. And then, of course, the big elephant in the room is artificial intelligence. I would say that I'm really, really excited about where things are heading in this space, to be quite honest. I think there's a lot of buzz. There's a lot more sizzle than steak right now, and I say that as a vegetarian. But I will say that AI does have a lot of potential to really revolutionize oncology, and I think that this may happen at least in 4 areas that I see, in addition to drug discovery, which is not my forte, so I won't go into it now. But I do think it has tremendous implications on small molecule design and in the way that we actually do drug design, even in academia as well. But so for one, I think using AI for diagnosing cancer can be really helpful. So we actually already have a few FDA-approved use cases where we can actually take patients who have had a mammography, for instance, or even prostate biopsies. And what studies have shown is that AI models are actually able to diagnose cancer at equal or higher rates than board-certified pathologists, though. Okay, so this is actually really interesting because I think that it's not necessarily going to replace these physicians, but I think it will augment the ability that they're able to diagnose cancer. This was a machine learning model that was developed out of Stanford, and it was actually able to, it was a classifier that was able to diagnose melanoma at a superior rate than board-certified a dermatologist, actually. So I think that these will be very helpful in terms of aiding physicians. The other area that I think will be very exciting is predicting treatment response. So right now, one of the things that's really difficult in oncology is that we don't have a great way of knowing and predicting if a patient is going to respond to certain treatment. Back in the day, even for Dr. Neil's clinic, like he would see a patient with lung cancer and they will give everyone chemotherapy and hope that it kind of works, and then you find out maybe 2 or 3 months later if it did or not. Now, from the work that he's done and many others, we have certain biomarkers like this EGFR mutation that you probably have heard of, ROS and ALK mutations that help essentially serve as biomarkers to help us determine if certain therapeutics would be beneficial for those patients. So it's really a great model actually for the rest of cancer. The problem is that we don't have those biomarkers in a lot of cancer still. We're still driving blind. So when I see a patient with metastatic bladder cancer, for the most part, I'm still giving them first-line treatment, crossing my fingers. I hope that it works, but I don't know if it actually will or not. Same thing, I just saw a man with prostate cancer. We're giving him radiation and hormone therapy, hoping that it all works, and there's a good chance that it will. But in the back of my mind, I'm always asking myself, well, was that hormone therapy actually necessary? Maybe I could have gone away with just radiation with no hormones, right? So these are the kinds of questions that we're asking, and I think that actually AI will be very helpful in terms of de-escalating care. Maybe that we didn't need to give all that care to still get a curative response, right? So here is actually a model that's been trained on clinical trial data from 7 different clinical trials where we have tons of prospective data, and we have definitions of who responded and who didn't to hormone therapy when they received radiation for their localized prostate cancer. So from this data, we actually have this group has actually produced a AI-derived biomarker. So if you just send your pathology samples, the actual path, H&E slides, as well as your PSA, as well as a few notes about your clinical course, it will spit out a determination if you should actually consider radiation, or sorry, hormone therapy in addition to radiation, or just do radiation by itself. And it's actually very predictive. And again, we don't have great explainability. Like, we don't know exactly what the algorithm is actually using to determine that. But it's much more sophisticated than our traditional models, which uses things like Gleason score that you may have heard about in prostate cancer, or their PSA. It's using a lot more information that we just didn't have before to be able to determine if patients should get hormone therapy. So I think this is one concept of a biomarker, and I think there'll be many more going forward. There's another one recently in lung cancer, where you can actually predict if a patient is going to respond to immunotherapy, not based on some type of biomarker like PD-1 status or PD-L1 status that you may have heard of in your biology classes, but based on just the appearance of the nodule on the CT scan. So this is called a radiomic biomarker. And so just by the appearance of the nodule on the CT scan, you can actually predict, should I give this patient immunotherapy or not? So that's really exciting. We're doing some similar studies in prostate cancer now, and excited to see where that takes off. I think we'll just keep on going. Is that all right, guys?
Okay.
Yeah. We don't let anything discourage us in oncology. You can see it. So for the last thing, as we mentioned, the AI co-pilots, kind of what I discussed before, though. So I don't think we'll be putting anyone out of business anytime soon. But I do think that pathologists are going to be very much aided by these electronic decision support algorithms. So here's an example of this program called PLIP. And what it does, a pathologist sees a slide that they may not be familiar with. So they're going through the pathology and they say, I've never really seen this before. They can upload that to PLIP. And PLIP is this AI platform that not only tells you what it thinks that it is, but it also cross-references across the internet to see if there are other images like it, and just pull in the discussion of what other people thought that was. So you can see here that it actually pulls in Twitter to talk about what other pathologists around the country thought about a sample that looked exactly like that. And then in terms of patient-facing applications, I'll just say that LLMs are great, and I think one of the best use cases is just that we can actually make information patient-friendly now. 2/3 of America actually reads at a 6th grade level. And so when you're seeing these consent forms, they're actually pretty complicated, to be quite honest. Like, the wording in there is not easy to understand. Can we actually just use LLMs in the same way you guys use it for classes probably, and just to simplify surgical consent forms and make it really patient-friendly? So I think that actually is another really useful application. So again, I'll just end by saying that oncology care delivery is likely to be transformed by digital health interventions in the next decade, and in some way or another. Care is likely to become more decentralized if we can get through some regulation. AI has a lot of impact in terms of the promise of it, from everything from diagnosis to actually treatment selection. And then the one thing I do want to say is, though, and I think Brian brings up this point every time he meets you guys, is that we're unlikely to be replaced, because at the end of the day, you need someone to hold your hand. You need someone to put an arm around you and to comfort you. And that's something that a robot's not going to do anytime soon. So while I think that we're going to do some...
Attention, fire alarm activation, SHC, 500P, women's restroom, room L as in Larry 2, R as in Robert, O2, second floor. Attention, fire alarm activation, 500P, women's restroom, room L as in Larry 2, R as in Robert, O2, second floor.
Okay, just don't go down to the second floor right now. And then, but I honestly do believe that, and it took me a while to understand this, because I used to always put so much onus on myself as an oncologist to always get the right diagnosis, to always get the right treatment, and I obviously think that's very important. But I truly feel at this point, the vast majority of my job is just being there and being present. And if you can do that for your patients, I think you're doing much more than any AI company will ever do for any of their patients. And so just by sitting here and being engaged, I think is the best gift that you can give anyone that's going through this, though. So with that, just want to thank you all for your time. Thanks.
Yeah, thanks for this talk. On your point about human connection,
Yeah.
do you think that a move to decentralized care will negatively impact the patient-physician connection, especially for like more historically marginalized communities who might be distrustful
Yeah,
of medical care?
it's a great point. I think it's really, the question was, as we move into this decentralized model, are we potentially disrupting that relationship between the patient and the physician, especially in more marginalized communities? And I would say that it has potential to do that. I think we have to, one, just be very cognizant that that could be an opportunity, that could be a reality. But more importantly, I think it's still important that we still meet patients where they are, though. So I still think that, we can't remove that physician-patient relationship. While care may still be done in the home, you can still have physicians as well as nurse practitioners and physician assistants still be a part of that patient's journey, but just it'll be in a different way. And I think there actually be as opposed to less touch points, I think you actually have more touch points during that time, though. So I'm hoping that it can hopefully augment and maybe get to patients who were previously marginalized in other ways. I know Dr. Neal has a lot to talk to you guys about too.
Great.
Yeah. Sorry, Joel. Thanks.
All good. Sorry about the fire alarm.
Thank you, Dr. Shah, and thank you for, your tolerance of the
Yeah.
fire alarm. It actually is funny, this thought came through my mind. In a way, it's like having cancer, right? You live your life, and there's always this thing in the background, you have cancer, you have cancer, you have cancer, but you got to kind of ignore it. And at some point, you start to ignore it, and you're like, okay, that's part of my life. There's this alarm going off, but, I'm just pushing through. So it just made me think of that when you were pushing through the talk. So thank you for doing that. I'd like to welcome Dr. Joel Neal, fantastic oncologist, going to talk about the future of lung cancer care. He's one of our experts. I think you do more clinical trials than probably anybody in at least the thoracic oncology group, right? Yeah. So join me in welcoming Dr. Neal.
Thank you, everybody. I was actually hoping to go first because I know Dr. Shah is a much better presenter, much more entertaining. He can even talk through a fire alarm. So, I knew he was going to be a tough act to follow. Plus, he gets you dreaming about everything in oncology and medicine in general. We're going to focus on it and drill down a little bit in lung cancer itself. So I know that Dr. Heather Wakely, my close colleague and the first person who ran all the clinical trials in lung cancer, and I inherited most of them, gave you a talk about the basics of lung cancer. So Bryant asked me to dream a little bit and say, what's going to be big over the next 5 or 10 years? He also wanted me to dream about digital health, and that's why I invited our expert, Sumit Shah. So when I think about what are the big things for the future of lung cancer, if the, here we go. All right, here's some learning objectives for you. Plus, no talk is complete without the image from Dolly. And if you haven't, when you talk about the future of lung cancer treatment, you get something like this, right? If you put it in a Dolly. Those of you who have access to AI tools right now, if you're not using securegpt.stanfordhealthcare.org, it's free, it's open to you, it's PHI secured, it's privacy secured. It's a tool available to everybody who's part of Stanford with a SUNET ID. So I encourage you to go in and use it. Please don't use the tools on the internet. They will assimilate your information. And HIPAA things aside, you really just don't want to give your private information to the internet. You realize that before, hopefully.
Attention, fire alarm, all clear. Attention, fire alarm, all clear.
I was actually debating whether we could just walk outside and do the talk, and we don't really need slides, we could just envision the pretty AI pictures. But I think number one, what do we have to do in lung cancer is first we have to detect it earlier, right? And in order to detect it earlier, there's a couple of different ways that we can think about that. One of them, the most obvious, is imaging. We don't have nerves inside the cells of our lungs. Sometimes people get cough, but most of the time lung cancer is diagnosed when it spreads to other parts of the body, when it causes pain in the bones, when it causes discomfort, when it's really central and causes more coughing. We don't feel little tumors in the lungs. And we have screening, low-dose CT screening, which was shown to be superior to the comparator chest X-ray. Not that great, right? Low-dose CT screening has been shown to be superior to chest X-ray and reduces lung cancer mortality by 20%, doing it annually for at least 3 years, but only in patients with a heavy smoking history. So this is the challenge. As the amount of smokers goes down, the baseline of lung cancer with all these targetable alterations that are genetically very simpler, like EGFR, ALK-ROS1, et cetera, These are very genomically simple lung cancers that were probably always around 150, 200 years ago, but we never detected them because we couldn't see based on CT scans that they existed. So as smoking goes down, which we all agree is a great thing, preventing lung cancer is very important. There will always be a baseline like there is for kidney cancer and colorectal cancer and breast cancer and everything else. If we can detect that earlier, that's going to be important. So right now, the screening for lung cancer guidelines are age 55 to 80. Originally have been revised to 50 years old to incorporate a different population, and then revised from 30-pack year smoking history to 25.
Attention, fire alarm all clear at 500p, second floor.
We got the message.
Attention, fire alarm all clear at 500p, second floor.
Still good to avoid that restroom. So have been revised from 30-pack years to 20-pack years and down to 50 years old to incorporate more patients, but requires a smoking history, right? So how do we address that non-smoking associated lung cancer? Interestingly, so one of the things we're doing at Stanford is actually changing from pack years. So we've looked and played with the modeling. And if you use pack years of smoking, so that's a pack a day for 20 years, for example, or 2 packs a day for 10 years, that is somewhat biased toward how you collect the information in the electronic medical record, and also somewhat biased toward, let's say, underrepresented minorities. So we played around and looked at the minority demographics, particularly Hispanics and Black African Americans, and found that if instead of pack years, if we just look at total duration of smoking history, so it could be 3 cigarettes a day for 30 years, is actually incorporates a lot more of those underrepresented minorities into the lung cancer screening. And now Summer Han and others are actually going to go to the U.S. Preventive Service Task Force and say, maybe we should change it to smoking duration as opposed to pack years. So what do we need to do to make it better? Well, I think better nuclear medicine tracers are one possibility. So we've been very excited. So PET CTs are amazing, right? Like, patients with cancer get a PET CT. What are the limitations of PET CTs? Because of the width of our bodies and the detection of the PET, we can only get 1 centimeter resolution from PET CTs. We can't see anything less than a centimeter. A centimeter of tumor is 1 billion cells of cancer. So a millimeter is 1 million cells. That's still a lot of cancer. But now there have been newer PET tracers. So first in neuroendocrine cancers of dotatate PET, which looks more specifically at the somatostatin receptor and detecting that on cancer cells. And then also PSMA PET, which when I first saw the images of this, you can see millimeter resolution of bone metastases. So you can separate out a patient who seems to have stage 1 prostate cancer and say, look, there's actually 1,000 bone metastases. This is stage 4 prostate cancer, and we need to treat it as such. So these two have changed the game in specific kinds of cancer. And if we can find similar radio tracers in lung cancer, ligands that are on the outside of lung cancer that are relatively unique, we might be able to detect it when it's much smaller, especially in the metastatic setting. In addition, we need CT screening for people who haven't smoked, or some sort of screening for people who haven't smoked. So there was a recent meta-analysis. They've done studies of looking at low-dose CTs in never smokers, mostly from Asian countries. Over 30,000 patients have been screened on these studies. Detection rates are low, though. 0.1%, that's 1 in 1,000 to 1.1%. Positive predictive values are also low. So there's a lot of nodules that aren't lung cancer that then need a biopsy, need workup, and other things. So I think imaging is only part of how we're going to detect more lung cancer. Next, we also need to combine with blood biomarkers. So lots and lots of work has been done with blood biomarkers. Cancer cells shed all kinds of things into the circulation, the most famous of which currently is circulating tumor DNA. Basically, when tumor cells grow, they also die. So if tumor cells divided every 12 hours, they would overwhelm everything within a matter of days, right? But solid tumors are much slower growing, partially because they're dividing rapidly, and most of those cells actually die and shed things into the circulation. So circulating tumor DNA means that there's unique mutations inside the tumor that shouldn't be in the body normally that we can identify as tumor associated because they're mutant. RNA molecules we're looking at, protein molecules, microsomes, little tiny bits of cells that peel off, and even the entire circulating tumor cell itself can go into the circulation, float around, and be used to detect cancer. So some of the interesting stories here, applications range all the way from screening on the far left to monitoring of therapy before you do surgery or radiation or something else, looking for relapses before we can actually see it on imaging, giving adjuvant therapies, additional therapy if we think that there's a high risk of cancer coming back or it's still there, monitoring response, and even looking for resistance to therapy. So we're using blood-based methods in all of these realms. One of the most interesting, and we can't take credit for at Stanford, is this. This is the data from GRAIL. And GRAIL has an approved blood test to detect 20 cancer types. Is it sensitive? It's not that sensitive. So enrolled 6,000 patients, had true positives of 35. That is a very low number of patients that actually had cancer. Had false negatives of 86, so doesn't detect every single cancer type. And actually, most of the lung cancers that they missed were early stage, so I looked particularly at the data in lung cancer. And 8 of the 11 total individuals did not meet task force screening. So, do I recommend that you go out and get the blood test, which may be $500, $1,000, I don't know. I don't work for them. I don't have any intellectual property, but, should you get the blood test? Probably not. We need to develop this more. But this is a methylation-based DNA assay, which does have the potential to find multiple kinds of cancer, and I think is promising. The one case of lung cancer they detected by their blood test was stage 3, as it turns out. Early stage is harder to detect. So how do we improve blood-based detection? This is work from Max Dean here, and we've been close collaborators with Max Dean and Ash Liziday over the last decade in saving many of the specimens from our patients who are giving us extra blood to do for research and save in freezers, and looking at how do we improve circulating tumor DNA assays. So, you can find one mutant molecule in 20,000 molecules with the first generation of this assay. With the next generation of this assay, one mutant molecule in 68 million is the limit of detection. So, we're not just talking about here's a lot of DNA looking for needles in a haystack and what color those are, but this is 1 in 68 million, really, really sensitive. And we're still looking at analysis beyond DNA of RNA profiling and protein signatures too. Okay, so once we detect cancer, hopefully we're going to end up treating earlier stage disease, right? We'll have smaller tumors. We'll be able to use the existing techniques of surgery, radiation, very focused radiation. We have amazing radiation techniques now that are, intensity modulated, the machine called the CyberKnife, very, very focused. We're even calling radiation radiosurgery without actually using a knife. They're that focused. So how do we use blood-based detection? Well, we can look for patients who have tumor, who get surgery, and then after surgery, try to separate out, are there patients who still have signatures of tumor in their blood? Normally after surgery or treatment, those signatures from cancer should fade away after a couple of weeks. But in some of them, if we're looking for circulating tumor DNA, we can still see those signatures in the blood. We're actually running a clinical trial. This is over half enrolled, and I wrote this with Max Dean. And for patients who have early stage lung cancer, who got surgery with or without chemotherapy, not getting immunotherapy, that's a standard of care, but not appropriate for everybody, we're actually doing this test called MRD. So MRD, one of two things, minimal residual disease, but I prefer the term molecular residual disease. So looking for DNA still sitting in the blood after surgery, after we think we got rid of the cancer. And then for patients MRD positive, we'll give them durvalumab or durvalumab plus chemo, that's immunotherapy, just trying to get rid of what might be left. And then the primary endpoint of the study. So when we think about endpoints in clinical trials that are meaningful, we think about shrinking tumor, but we couldn't really see it here. We think about overall survival. Hopefully that's years and years long endpoint. So the endpoint for this trial is actually just saying, we had a positive test here. Can we make it go negative, right? Can we make the positive test go negative as hopefully a surrogate for survival? Number 4, overcoming resistance to therapy. So here's the problem with solid tumors is if all of the tumors were exactly identical, we should be able to figure out the gene that's wrong, give a pill, and kill 100% of the tumors. The problem is tumor heterogeneity. So every tumor cell, the process that led to cancer in the first place, which was mutagenesis, the process that led to that means that every cell is slightly different than every other cell inside any given solid tumor. And so when we treat with targeted therapies, we kill a lot of them, but there's a few drug-tolerant persisters here. If we keep that treatment going, then they grow out, and then they can become resistant and even heterogeneous. So, when I think about which of these two therapies is which of these two theories is happening, are the mutations already there causing resistance, or do they actually evolve over time? I think most of them are probably there, or at least the environment was right for the resistance to be able to emerge, as opposed to the tumor cell changing from genotype A to B. A little bit of genotype B was there, and that's leading to the resistance in the first place. So how do we overcome this? Well, these are all the strategies that we used for treating lung cancer over time. Dr. Wakely probably talked about a lot of these. Chemotherapies, and a whole long list of them over on the left. Targeted therapies all throughout the middle across a variety of targets, including VEGF and EGFR and others, and then immunotherapy checkpoint inhibitors. But clearly that in stage 4 lung cancer isn't enough. Here's another way of looking at all the therapies that we have now, all the targeted therapies, but we're still seeing this little bit of residual resistance afterward. So how do we overcome? Some tactics are treat resistance early, combining therapies, so putting more than one modality together to try and get to more minimal residual disease states, adding radiation or surgery. So we have consolidative studies where we'll take patients, try to get it to a minimum amount, and then hit with radiation. That's for oligometastatic disease, a little bit of metastatic disease. New therapies to eliminate drug-tolerant persisters. And I don't know what those are, but hopefully this talk will inspire you to dream and do research and figure out how do we overcome these things. And then ADCs and radioligands, I think uniquely have this effect of bystander cell killing. So instead of using a genetic target and killing one cell at a time, they can actually kill a group of cells around. So I want to expand on that a little bit. So ADCs are basically an antibody combined with a chemotherapy, and they have a linker in between. So we're taking the chemo and we're trying to target it directly to a cell. It goes inside the cell. These chemos are so toxic that we can't give them by a vein. They're just too toxic. But if we give them inside the cell, they'll actually kill a cell, they'll remain active, and they'll kill some of the cells around it. So I love this concept of bystander cell killing, and I wonder if, for example, in adjuvant therapy, where we're trying to kill little deposits of metastatic cells that might be around, if ADCs might be a little bit more effective. In addition, there's radionuclides. You can actually conjugate radiopharmaceuticals to antibodies as well, or any other sort of ligands, and you can use that to kill tumor cells as well. One of the cool things about radionuclides is you can actually have a detection system. So you can detect like with a PET-based version of the antibody, and then you can decide, is the tumor active? And if the tumor is active, then you can give the treatment version of the radionuclide too. So we have some clinical trials emerging in this. And then finally, like everybody loves immunotherapy. Back when I was a tumor cell biologist getting my PhD in an immunology lab, everybody wanted to use the immune system to fight cancer, right? And nobody could. And then PD-1, PD-L1 came around. But anti-PD-1 and PD-L1 is basically just taking advantage of the tumor protecting itself from the immune system. So there's immunity trying to happen, and there's a shield set up, and we're breaking down that shield. But how do we activate the immune system? And there's a couple of new therapies that are exciting. One of the examples of a trial that we ran was transgenic T-cell therapy against a target called NY-ESO-1 that's on a lot of lung cancer cells. Who's heard of CAR T-cells? Hopefully you had a lecture about that. They don't really work in solid tumors because the nice thing about CAR T-cells is you can eliminate every CD19 molecule from the body and you can still be okay. You can't eliminate every NY-ESO-1 molecule or anything else that we know of on a non-small cell lung cancer cell and still be okay. So we have to titrate that immune system a lot more carefully rather than saying seek and destroy every protein that's out there. That's what cars do. So the problem with this strategy, though, and we just published this, is we had to screen 1,698 patients to treat 20 down here, because we needed match of the HLA, we needed expression of the target on the tumor, and we needed the patient to be at the right point after we did all of this screening that took a couple of months in the first place. So hard strategy, one that we thought about, but hard. You can make it easier, though. So bispecific T-cell engagers, off-the-shelf therapies, which are bringing together some sort of protein and a T-cell. So it binds to CD3, and it binds to a protein at the same time with a bispecific T-cell engager. And we have our first FDA approval of this in solid tumors, tarlatamab, in small cell lung cancer, and it works. And not only does it work, and it's in the second line treatment for lung cancer, but it actually, there's a tail on the curve of longer term survivors, thinking that we're actually eliminating a whole lot more cancer than we thought we could have, and this immunotherapy is effective. So boosting anti-cancer immunotherapy, certainly what we need to do. Here are my conclusions, and same Dolly picture there. But basically, you know, let's detect it earlier, and then let's come up with better treatments to overcome resistance and boost the immune system. Those are what I'm envisioning over the next 5 or 10 years. So this is our thoracic oncology group, and I think we're at time. Thank you.
Great.
Happy to take some questions.
Yeah, thank you so much, Dr. Neal. I think we have time for one question because we did get a little late start. Any questions? I guess a selfish asking for a friend, as I said to Heather. So say you've got somebody with EGFR mutation on osimertinib getting resistance, right? So what's on tap for that person, say 2 to 3 years down the line?
Yeah, so resistance, I didn't show all the EGFR pictures of all the ways that we understand resistance, and really it comes down to tumor heterogeneity. So what are the pre-existing pathways that are important? What are the pathways that we may not understand yet? I think we have to understand that. So we do blood-based biopsies, and we can see a lot of the circulating tumor DNA. We like to do tumor biopsies of the growing lesion, say, what is the mechanism of resistance? So there's, in general, resistance is on target, so mutations of the target, or bypass tracks, so activation of other pathways around. Separating those two out can tell us, do we want better EGFR inhibitors, or do we need to inhibit the other pathway? But hopefully in the future, we're gonna figure out how to harness the immune system too. You know, wouldn't it be cool to have a bispecific T-cell engager against that mutant EGFR protein where we're like, okay, immune system, go and actually activate and fight the cancer. That's where we need to be, I think.
That's awesome. I mean, my friend is depending on you, so.
Happy to help.
Thanks. Yeah. Thank you, Dr. Shah and Dr. Neal. I know we're getting close to time, so just a few remarks. You know, I originally had kind of 1 or 2 hopes for the class. So one hope was what Dr. Shah had spoken about, which is really showing you how, in my opinion, all of medical care is really about people. It's really about the humanity. All of this stuff, the science, the digital tools, everything are just ways for us to support and deliver that support and care for humans. So medicine can't be, I don't think doctors or anybody can be replaced by AI because it's such a innately human endeavor we're undertaking. So that was my one hope, which is hopefully you understood a little bit more about that aspect. A second hope was, you know, hopefully some of you, many of you will go into either cancer care research, like Dr. Neal, Dr. Shah, or cancer care, oncology, or like Dr. Neal and Dr. Shah, or primary care. I'm a primary care doctor, and I've had a great meeting with a cancer patient earlier today who had a lot of questions. So my hope was that at least some of you, who is going to plan on taking care of cancer patients or doing cancer research in the future? Anybody? Okay, great. So I told a lot of people, I said, that's an easy one. I'm sure we'll get some people who are going to go into cancer care of some sort, primary care included. And my third hope was a new one, and I think this is a reflection based on how many people have reached out to me about the class. And I would love all of you to think about ways to educate, in novel ways to educate our next generation, because that's a magnifying effect, right? We've got, I guess, 31 official people, but many more unofficially enrolled in the class. So I hope you will all think and consider a career in education and thinking of new ways to educate our next generation of leaders. Yes, Skip.
I think maybe on behalf of the class, I think just a word of thanks. I don't know if the people here can understand or appreciate what is needed, that you so embody, that your first instinct was with your illness to try to see how you could use it to help the people sitting here. So I think on their behalf, thank you for exposing people to a different side, or actually to all sides of this disease. It's not just one thing, and it requires everything we've got, as you said, that fire alarm bell, something that people
It's always there, yeah.
really understand, but for people who experience it, that's what their life is. Their life is like. Do you have any thoughts for people who are generally interested in cancer, who'd like to learn more across the
Yeah, I think.
range of things? Where would you direct them?
Yeah, I think that's a great. Thank you for, first of all, thank you, Skip. Thank you for your support and your kind words. I would say, talk to people like Dr. Neal and Dr. Shah. That really. I mean, of course, you've got the classes and everything like that. But again, circling it back to the human side of it, nothing really replaces having a mentor or having a direct relationship with somebody who's involved in the care or receiving care. So I'm happy to talk with students as well. But thank you for those comments. I wanted to leave you with one thing. Who knows who Lou Gehrig is? Gehrig, so famous, of course, in medicine because of ALS and Lou Gehrig's disease. You never want a disease named after you. So unless you discovered it, I guess. But usually it's not. It's a famous person. So I was always inspired for years when I was even a kid. I'm not a Yankees fan, by the way. Who's a Yankees fan? No, okay, good. Not too many. Not too many. I'm a Red Sox fan. I still remember I was in residency when the Red Sox overcame a 3-0 deficit against the Yankees, and I remember being in the emergency room with a bloody sock, and literally chest pain, car crash. Everybody stopped. ER was silent, which is incredible. I mean, this again, linking back to the human side, right? Why are sports so appealing? It's the human nature of the endeavor. But he's always inspired me because, even though I'm not a Yankees fan, he's famous for how many people know his luckiest man in the world speech. So I've always considered myself that. So he's always, before I got sick. So I wrote a version, my version. I wrote, this is Bryant's version. So Lou Gehrig gave a speech on July 4th, 1939. He died not quite 2 years later. So my version of the luckiest man speech. So with, I hope Lou Gehrig will forgive me somewhere. For the past quarter, you've been hearing about the bad break I got, yet today I consider myself the luckiest man on the face of this earth. I've been at Stanford for almost 20 years and have never received anything but kindness and encouragement from my patients, students, and colleagues. Look at these amazing people. Which of you wouldn't consider it the highlight of your career just to associate with them for even one day? Sure, I'm lucky. Who wouldn't consider it lucky to have friends spend their valuable time to make a documentary about your cancer journey? Who wouldn't consider it lucky to have 2 healthy, happy sons who bring joy and laughter into my house? Who wouldn't consider it an honor to have known Richard, Liang, Longsha Lu, and Stephen Trong, who volunteered this thankless activity of being our TAs for the class. Once I told them about my crazy idea, and Longsha led to Richard, who I also knew, who led to Stephen, who I also already knew. So, who wouldn't be considered lucky? To have spent the past 3 years with our world-class medical humanities team, and the past 6 years with our world-leading Asian health team, who wouldn't be considered lucky? When you have students and former residents reaching out to pray for you, chant with you, and wish you well, that's something. When you have patients who send you gift baskets and messages of hope, that's something. When you have friends you haven't seen in years send you food and offer to drive you and your kids anywhere needed, that's something. When you have a father and mother who worked all their lives to send you to medical school, it's a blessing. When you have a wife who's been a tower of strength and shown more courage than you dream existed, that's the finest I know. So I close in saying that I may have had a tough break, but I have an awful lot to live for. Thank you, and it's been an honor. Please stay for the concert, 10 minutes, have some food. Thank you.